Hello everyone. So this video is on the physiology of bone and calcium metabolism, and also to describe the synthesis, secretion, transport, physiological actions, regulation, effect of altered, that is hypo and hypersecretion of parathyroid gland. So to introduce you to the topic, calcium is derived from the Latin word that is calx or calcis, which means lime. So the total calcium concentration is 1,100 grams, out of which 99% is in bones and 1% is in the body fluids, out of which 0.1% is in the ECF. So if you take up the total calcium levels in the body, it is in the form of anions, which is just 9%, which is protein bound, which is 41%, which is ionized to the calcium, which is 50%. And why do we need to study about the calcium homeostasis? Why? Because calcium serves a lot of physiological roles in our body, like contraction of skeletal, cardiac, and smooth muscles. It helps in the blood clotting, in the transmission of nerve impulses. It helps in membrane stabilization. It also acts as a second messenger. So to completely study about the calcium and phosphate metabolism and the hormones affecting them and all about the parathyroid gland, let's first study about the bone physiology. You know that the bone is composed of the tough organic matrix, which is 30%, and salts, which is 70%. The salts include hydroxyapatites. The tough organic matrix includes collagen and ground substance, which is 95% and 5% respectively. And whenever the bone is being newly formed, it has more matrix in relation to salts. Otherwise, it is more salts in relation to organic matrix. So the bone structure, if you consider, you know that there is a cortex and then there are multiple things inside the bone also. All these you will study in your anatomy. But still, an overview of the bone structure, if you would want to give, there can be an epiphyseal line. There is Haversian canal in between, outside which there are osteons. And you could see the bony canaliculi and lacunae. So here, if you want to imagine that in a vertical actual bone, so these are the lacunae, and that is the canaliculi. And then you can see the bone also has got resorption spaces, that is from which the resorption of bone in the form of calcium happens, right? And then you can see the osteons there. At the center of the osteon, you will get the Haversian canal. So there are multiple cells in the bone, that is the pre-osteoclasts, and which turn into active osteoclasts. Osteoclasts, what is the function of osteoclasts? It is the bone resorption. Then there are pre-osteoblasts, which convert into osteoblasts. Osteoblasts are the ones which are helpful in bone formation. And then are osteocytes. Osteocytes are helpful for bone mineralization. So this you should be very much clear of. Clasts cause resorption, blasts cause bone formation, cytes cause bony mineralization. So when I say bone mineralization, it is addition of salts, that is calcium and phosphate to the bone and thickening the bone, right? So the mechanism of bone calcification. So you know now that the osteocytes are necessary for bone mineralization. So mineralization is nothing but calcification, right? So of course, as you know till now, the bone is composed of the collagen molecules and the ground substance, right? So the collagen fibers all undergo polymerization, and then there is a formation of an osteoid. And in its amorphous form, you have hydroxyapatite crystals. Hydroxyapatite crystals will start accumulating later to the ground substance, which will thicken the bone, hence the calcification, right? So once we enter into the calcium metabolism, so when somebody asks you to talk about, give a note on calcium homeostasis, then firstly you will talk about calcium metabolism, and then you will talk about how the calcium levels are maintained within the normal limits, for which you will have to explain when the calcium decreases, what all happens, and when the calcium increases, what all happens. So firstly, to know the calcium metabolism, meaning, so the food that you take will have some calcium in it. So once it goes inside, what all is going to happen further? So the calcium intake per day is considered to be around 1000 milligrams that a normal average person takes in. It goes into the stomach and then into the intestine. In the intestine, from out of 1000 milligrams per day of whatever you're taking in, 350 milligrams is absorbed per day by the intestine, which enters into the extracellular fluid, right? So from this, 250 milligrams is secreted into the intestine. Okay, so out of 1000, 350 entered into the extracellular, 250 entered back into the intestine, right? So that means the 900 milligrams per day is excreted out through the feces. So extracellular fluid has got 1300 milligrams of calcium in it, right? So this will be absorbed by the cells, and cells will again give back the calcium into the ECF. But this total stores in the cells is 13,000 milligrams. The extracellular fluid, say blood for example, you know that the blood is passed through the kidneys for its filtration, right? So around 9,980 milligrams per day of it is being, of the calcium is being filtered through the kidneys, out of which 9,880 milligrams are reabsorbed back, but only 100 milligrams per day is excreted. So can you note this down, that the total calcium intake was 1000 milligrams per day, and total excretion is also 1000 milligrams per day. Why? As to maintain the normal levels of calcium. So it is very important to maintain the stable levels of calcium in the body, as hyper or hypocalcemia can create problems with all muscles and every system in the body, right? From the extracellular fluid, the calcium is being utilized for the mineralization of the bone, or say deposition in the bone to form the thick bone, right? So 500 milligrams per day deposits on the bone. So in the bone, the stores are around 10 lakhs milligrams or 1 million milligrams. So if 500 milligrams per day from the ECF is depositing on the bone, the 500 milligrams per day is being resorpted into the extracellular fluid. So totally, if you can see, there are more stores in the bone and also in the cells, also in the ECF. But though the total intake is 1000 milligrams, it is being excreted equally through feces and urine as to maintain the stable levels of calcium. So what is the total amount of calcium in your body? It is around 10 milligrams per deciliter of the total plasma calcium that which is present. It can be present in the diffusible form or in the non-diffusible form. So when I say the total diffusible forms is around 5.36 milligrams per deciliter, out of which 4.72 is as ionized calcium, another 0.64 is complexed to carbonates and citrates. Another 4.64 milligrams per deciliter is protein bound, which can be bound to either albumin or to globulin. 3.68 milligrams is bound to albumin, 0.96 to globulin. So total of around 10 milligrams per deciliter is the normal plasma calcium levels. Right. Now, as I said, through the ECF, from the ECF, most of the calcium will pass through your nephrons, right? That is the kidney, out of which 60% is being reabsorbed through the paracellular pathway in the proximal convoluted tubule. So if you just look at this diagram of the nephron, so that is your glomerulus, that is your proximal convoluted tubule, and then the Henle's loop, the thick ascending limb, the DCT, okay, and the collecting duct, right? So from the PCT through the paracellular pathway, 60% of the calcium is being reabsorbed. Okay, so then through the thick ascending limb, again through the paracellular pathway, it is being reabsorbed. How it is based on the extent of sodium reabsorption. The calcium is also absorbed. There are sodium calcium exchangers, right? And then there is transcellular pathway. Through the transcellular pathway also, the thick ascending limb absorbs calcium. So earlier in the previous slide, if you had seen here, out of 9,980 milligrams that is reaching kidney, 9,880 is reabsorbed, which means around 98 to 99% of calcium is reabsorbed. So all through the kidney, different parts of the kidney, whatever I'm explaining is in terms of reabsorption, not secretion. It is reabsorption. So at the level of PCT, it is paracellular pathway, and 60% of it is reabsorbed here. And then in the thick ascending limb, through the paracellular pathway and transcellular pathway, there is reabsorption of calcium. Okay, and the extent of reabsorption of calcium depends on the extent of sodium reabsorption and the presence of parathyroid hormone and calcitonin. That is at the level of thick ascending limb. Next is the distal convoluted tubule, wherein the reabsorption happens through transcellular pathway, and that is again dependent on parathyroid hormone, calcitonin, and vitamin D. Of course, there are epithelial calcium channels that are present here through which the reabsorption takes place. Okay, so that is all about the calcium metabolism, right? Next, we study about the phosphate metabolism. So the phosphate, see, when we study the calcium homeostasis, it becomes very important to study the phosphate metabolism and homeostasis because they both go hand in hand, right? So out of 1,400 milligrams of phosphate that we take in through our diet, that goes into our GIT, under the presence of vitamin D, there is reabsorption of the phosphate, out of which 500 milligrams per day is excreted through the feces. So whatever is being taken in through the diet, under the presence of vitamin D, there is 1,100 milligrams that which are reabsorbed per day through the intestinal epithelium that enters the ECF, where there is 500 milligrams per, and that enters the soft tissues, and then there are the stores of only 100 milligrams in the soft tissues, right? From the ECF phosphate pool, 10 milligrams per day helps in bone formation, wherein there is only 600, there is 600 grams. So see, these are all in milligrams that which we are studying, but here it is in grams. Can you see? Those phosphate stores are about in 100 grams in soft tissues and 600 grams in the bone, right? Then that 210 milligrams per day, whatever enters from the ECF, is returned back to the ECF through resorption. Around 6,100 milligrams per day is being, 7,000 milligrams per day is being filtered through the kidney. Through the kidney, 85 to 90% of the phosphate is reabsorbed under the presence of parathyroid hormones and of course vitamin D, all that. There will be reabsorption and secretion of phosphate. Okay, so the secretion of phosphate happens under the presence of parathyroid hormone. There is 900 milligrams per day, which is excreted through the kidneys. So here you need to note something. 1,400 milligrams we are taking in, 500 milligrams excreted through feces, and 900 milligrams excreted through kidneys. So again, the total excretion is equal to that of the total input, so as to maintain the normal phosphate levels in your blood, right? So that returns back into the ECF is 6,100 milligrams. Again, 200 milligrams is secreted into the GIT. So how is all this calcium and phosphate metabolism being maintained? So we call it homeostasis when the calcium and phosphate levels are maintained within the normal levels within our blood, and that becomes very important part of the body or the homeostasis. Okay, so how is this being maintained? How is this homeostasis being maintained? Is most of it is through the hormonal regulation. Which are the hormones that regulate this? Are parathyroid hormone, vitamin D, calcitonin, and other hormones. So firstly, let us study parathyroid hormone. So to know about the parathyroid hormone, as I quoted earlier, we have the UG curriculum in which 8.1 and 8.2 we are dealing with today, right? So we have to know the formation, the secretion of parathyroid hormone, and then the increase or decrease in the parathyroid levels when that happens. And then you need to also know what is the actual effect of parathyroid hormone. Okay, so firstly, let us study where are these parathyroid glands situated. So if that is your thyroid gland, on the posterior aspect of the thyroid gland, do you find parathyroid glands? Okay, you can see there are 2 in number on each side, right? So you can see its relationship with the pharynx, thyroid, the carotids. Okay, so if you take a section of the parathyroid gland and take an histological section, you see that there are capillaries, the chief cells, and oxyphil cells in the parathyroid tissue, right? So it is see, both chief cells and oxyphil cells secrete parathyroid hormone, but majorly are secreted by chief cells. How? Depending on the calcium levels. Okay, so the chief cells have got the calcium sensors in them. So whenever there is an increase or decrease in the calcium levels in the capillary, that is sensed by the chief cells. Accordingly, the parathyroid hormone is released or inhibited from being released. So parathyroid hormone levels normal plasma value is 10 to 55 picograms per ml. So note the value here, it is 10 to 25 picograms per ml. And look at the half-life, it's so less of 10 minutes, right? So what is the main function of parathyroid hormone? It is to increase the concentration of calcium in the blood, which means when does the parathyroid gland secrete parathyroid hormone? Whenever there is a decrease in the plasma calcium levels, the chief cells sense that there is decrease in calcium levels and they start secreting parathyroid hormone, which acts to increase the concentration of calcium in the blood. So how does this now let us say there was decrease in calcium level in the body. Okay, so that stimulates the parathyroid gland, and the parathyroid gland now the chief cells are stimulated and the chief cells will secrete parathyroid hormone. Now, once the parathyroid hormone is secreted into the blood or the capillaries, it will reach its target tissue and it attaches to its receptor. It acts through the G protein, wherein adenylyl cyclase is stimulated and ATP is converted into cyclic AMP. So if you have seen my previous video, the actions of second messengers, you would have seen what are the actions of cyclic AMP and how does it act. Then through another G protein, there is phospholipase C activation, which will convert the phosphatidyl inositol into diacylglycerol and inositol triphosphate. Okay, diacylglycerol helps in protein kinase C activation, which helps in performing further actions of parathyroid hormone. Again, inositol triphosphate, it stimulates the endoplasmic reticulum to release all of its calcium from its store area, resulting in increasing the calcium release, right? So this is how the parathyroid hormone acts. Now, let us take a scenario wherein there is decrease in plasma calcium. So the chief cells in the parathyroid gland get sensitized by decreased plasma calcium. Therefore, they start secreting more of parathyroid hormone. Therefore, there is an increase in parathyroid hormone levels in the plasma. This parathyroid hormone now acts on the kidneys, increases the phosphate reabsorption, decreases the phosphate reabsorption, increases the urinary excretion of phosphate. Therefore, there is decrease in the plasma phosphate levels whenever parathyroid hormone is acting, right? But now its main goal is to increase the plasma calcium. How? It directly causes an increase in the calcium reabsorption at the level of thick ascending limb and DCT by decreasing, therefore, so if it is causing reabsorption at DCT and TAL, there is decreased urinary excretion of calcium, therefore increasing the calcium level. It also acts by activating the vitamin D. So parathyroid hormone is very much necessary to convert the inactive form of vitamin D into active form of vitamin D, that is D3, which will increase the intestinal calcium absorption and hence increase plasma calcium. Parathyroid hormone also acts on the bones. It causes bone resorption. So when there is resorption, more of the calcium is released into the plasma, therefore increasing plasma calcium levels. Okay, so now you know that whenever there is decrease in plasma calcium, parathyroid hormone is released, which acts on kidneys, decreases plasma phosphate and increases excretion of phosphate from the urine, increases calcium reabsorption in kidney, increases vitamin D levels, increased calcium reabsorption in the intestine, causes bone resorption. So final actions of parathyroid hormone is to increase the plasma calcium and decrease the plasma phosphate levels, right? So, of course, parathyroid hormone doesn't only act on calcium and phosphate levels in the body, it also acts on increasing chloride reabsorption from PCT and magnesium reabsorption from ascending loop and distal tubule in the kidney. It also decreases sodium and bicarbonate reabsorption from the proximal tubule of kidney. So those are the actions of parathyroid hormone specifically on the kidney. Okay, now as I said in the earlier slide that the PTH acts on the bone, causing its resorption as to increase the calcium levels in plasma. How does it affect these things? By increasing the activity of osteoblasts and osteoclasts, increases collagen synthesis. So what does it say? There are two things that you need to know here, that there are two phases there in the bone. That is, one is fast exchange phase and another one is slow exchange phase. Okay, so in the fast exchange phase in the bone, there is stable pool of calcium and labile pool of calcium. Okay, so in the fast exchange stage, what happens is the parathyroid hormone activates the calcium pumps which are located in osteocytic and osteoblastic bone membrane, resulting in exchange of calcium or release of calcium into the plasma. So fast exchange through PTH activated calcium pumps. Then during the slow exchange phase, the calcium is moved into that is from the mineralized bone, that is the stable pool of calcium, into the plasma through the PTH induced dissolution of bone. Okay, so this is how the resorption of bone is brought about by parathyroid hormone. Okay, so how does it exactly act for its resorption? Is by increasing the osteoclastic size and number, and also increasing osteoclastic collagenase and lysosomal enzyme activity, by increasing osteoclastic acid phosphatase, carbonic anhydrase, lactic acid, and citric acid concentration. So if you can see here, of course, you know what is the function of osteoclast is to resorped bone, right? That is resorption of bone. Along with that, there are multiple acids also that which are increased in concentration. Obviously, all these together should cause bone resorption. Of course, lysosomal enzymes also have got resorpting properties, right? So through all these things, it causes bone resorption, which mobilizes the calcium from its store into the blood, right? So if you can see here, the parathyroid hormone through its receptors will act on the cells, which by binding to the rank ligands that will activate the osteoclasts, which will release, the osteoclasts have multiple acids and lysosomes. There is secretion of all the lactic acid, citric acid, carbonic anhydrase, acid phosphatase. It also releases the lysosomal enzymes. All these together will dissolute the bone or cause resorption of the bone, hence releasing calcium into the plasma. Therefore, the plasma calcium levels are increased. So as to summarize the actions of parathyroid hormone, see, whenever there is a decrease in the calcium levels in the plasma, the parathyroid hormones are stimulated, the chief cells specifically. They increase the parathyroid hormone levels, which acts on the bone to cause bony resorption through osteoclastic acids and lysosomal enzymes, hence release of calcium into the plasma. Then it acts on the kidney. It acts directly on thick ascending limb and DCT. Also by increasing vitamin D, it causes increase in calcium reabsorption. It directly acts to cause decrease in the phosphate reabsorption, therefore increasing calcium levels in plasma and decreasing phosphate levels. It acts on the intestine. In the intestine, it causes both calcium reabsorption and phosphate reabsorption. Okay, so these are the effects of increase in vitamin D. PTH doesn't directly act on intestine, but it is through vitamin D. So what is the effect of vitamin D on intestines? It is going to increase both calcium and phosphate reabsorption, finally increasing calcium levels. So let us actually study about the vitamin D now. Okay, so vitamin D as such is not in its active form. How is this vitamin D being formed? So in your skin, there is something called, of course, you know that the skin also has more of fat in it, that is cholesterol in it, right? So there is this 7-dehydrocholesterol, which on irradiation by the ultraviolet rays of sun, okay, gets converted into cholecalciferol. Okay, so this cholecalciferol in the skin enters the liver, wherein in the liver, cholecalciferol is converted into hydroxycholecalciferol. This enters the kidney, wherein under the presence of parathyroid hormone, there is activation of hydroxycholecalciferol into D3. Okay, so this vitamin D3, which is now formed, will act through its receptor, which is intranuclear. Okay, so intranuclear receptor, it binds to, along with the retinoid receptor, binds to its vitamin D response element and activating the DNA, and then there is transcription and translation. Hence, the mRNA which enters into the cytoplasm, right? So in the cytoplasm, the proteins are being formed. Okay, so the proteins will now cause all the effects, the final actions of vitamin D. Now, what are the final actions of vitamin D, which is such form? It mainly acts on the intestinal epithelium, wherein it causes the increase in calcium binding protein. It increases the calcium stimulated ATPase. It increases the alkaline phosphatases, hence causing an increase in intestinal absorption of calcium. Therefore, there is increase in the plasma calcium concentration. So you know that whenever there is an increase in plasma calcium, what happens? It inhibits the parathyroid hormone synthesis in your parathyroid gland. When parathyroid hormone synthesis is decreased, and parathyroid hormone is necessary for activation of vitamin D. So if parathyroid hormone is inhibited, further vitamin D also will be inhibited from being formed, right? So how is vitamin D and parathyroid hormone being regulated is mainly through plasma calcium levels and plasma phosphate levels, right? So always there exists this inverse relationship between the plasma phosphate and calcium concentrations because of the solubility characteristics of calcium phosphate in your body. Okay, so whenever there is a decrease in plasma phosphate levels, okay, there is, so when I say there is inverse relationship between plasma phosphate and plasma calcium, and there is decrease in the plasma phosphate levels, it is going to inversely what? Increase the plasma calcium, right? Why? Because most of it is attached to calcium phosphate. There is calcium phosphate which is formed. Now, when phosphate levels are low, the binding of calcium to phosphate is less. Therefore, there is more calcium in its ionized form. Therefore, there is more or increase in the plasma calcium levels. So, what happens whenever there is an increase in plasma calcium? It inhibits the parathyroid gland, right? So, there is decreased parathyroid hormone. So, whenever there is a decrease in parathyroid hormone related reabsorption by kidneys is affected. Yeah, so there is increased reabsorption. So see, parathyroid hormone decreases the reabsorption of phosphate in the kidney. So whenever there is decrease in parathyroid hormone, there is increased reabsorption by the kidney. Therefore, urinary excretion of phosphate is decreased, which in turn increases plasma phosphate levels. Then whenever the parathyroid hormone levels are decreased, you also know that the PTH causes increase in the calcium reabsorption. So whenever the values of PTH are decreased, there is decreased calcium reabsorption by the kidney, resulting in increased urinary excretion of calcium. But there is no change in the plasma calcium. How? Because whenever there is decrease in plasma phosphate levels, the vitamin D gets activated in kidney. So this vitamin D increases the calcium absorption in the intestine, and it increases phosphate absorption also in the intestine. Therefore, there is increase in the plasma phosphate levels, but there is no change in the plasma calcium, because initially to start with, there was no alteration in plasma calcium, right? So plasma calcium is maintained stable, but phosphate values were decreased. Therefore, PTH decreased and vitamin D increased, resulting in final requirement, which is nothing but increasing the plasma phosphate. Okay, so the increase or decrease in phosphates and the calcium are going to regulate vitamin D and PTH, which in turn will regulate plasma calcium and phosphate levels. Okay. Now, whenever there is a decrease in the plasma calcium, this I've already talked to you about, that is parathyroid glands get stimulated, PTH is increased, that stimulates the kidney directly, causing calcium reabsorption, therefore increasing plasma calcium. It also decreases phosphate reabsorption, therefore increasing the phosphate secretion. But on the other hand, it is also increasing vitamin D activation, causing increase in calcium and phosphate reabsorption from the intestine. So here there is reabsorption of phosphate, here there is secretion of phosphate equally. So phosphate levels are maintained stable, because to start with phosphate was unaffected. But what do we want finally now is increase in plasma calcium, right? Therefore, parathyroid hormone through the renal tubular calcium reabsorption increases plasma calcium, and through bone it increases mobilization of calcium, that is resorption of bone. Therefore, plasma calcium levels are increased. Next hormone that which we need to study is calcitonin. Okay, so the calcitonin is secreted and synthesized by parafollicular cells of thyroid gland. Okay, so note this, parathyroid hormone is secreted by chief cells of parathyroid gland, but calcitonin is secreted and synthesized by parafollicular cells of thyroid gland, right? So when is this secreted? Parathyroid hormone was secreted whenever there was decrease in plasma calcium, right? So whenever there is increase in plasma calcium, calcitonin is secreted. So therefore, what should be the final main action of calcitonin? To decrease the plasma calcium levels. So whenever there is an increase in plasma calcium that stimulate the parafollicular cells of thyroid, there is release of calcitonin. This calcitonin acts on bone. It increases or it inhibits osteoclastic activity. Hence, there is decreased bone resorption and there is more mineralization, resulting in decreased plasma calcium. And of course, phosphate also, that is through kidney. So it acts on the kidney, where in the distal convoluted tubule of the kidney, it inhibits calcium and phosphate reabsorption, which means there is more secretion of calcium and phosphate, resulting in decrease in the plasma calcium and phosphate. So calcitonin plays a very important role also to protect the maternal bones from excess calcium loss during pregnancy and lactation. So how is the levels of this being maintained? It is through alteration in calcium levels. Whenever there is an increase in plasma calcium, there is activation of thyroid C cells or parafollicular cells, which release calcitonin, which will decrease the plasma calcium. But it will inhibit parathyroid glands. Therefore, there is decrease in the plasma calcium. So, but whenever there is decrease in plasma calcium, it stimulates parathyroid gland and it inhibits thyroid cells. So these are the negative feedback loops as to maintain the normal calcium levels. Okay, so there are other hormones also that you need to be aware of. That is glucocorticoids, growth hormone, insulin-like growth factor 1, thyroid hormones, estrogens. Glucocorticoids, they decrease the plasma calcium level by inhibiting osteoclastic activity, decrease calcium and phosphate reabsorption in intestine. They increase calcium and phosphate excretion in kidney and of course in intestine also. They cause osteoporosis when given in long term. Growth hormones increase calcium excretion in urine and they increase intestinal absorption of calcium also. But when both are considered, okay, there is increased intestinal absorption is more compared to that of excretion. Therefore, there is positive calcium balance maintained by growth hormone. Next is insulin growth factor 1, which stimulates protein synthesis in the bone. Thyroid hormones cause hypercalcemia and hypercalciuria. Okay, so whenever you treat a hypothyroid with excess of thyroid hormones, there are chances of osteoporosis. Estrogens prevent osteoporosis by inhibiting the cytokines that stimulate or that act on the osteoclasts. Insulin increases the bone formation. So there are few applied aspects which we will study in the next video.